Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home-related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar topic is Person-Centered Care's Influence in Long-Term Care Facilities. This is part one of a two-part series, so if you're interested in watching part two of today's webinar, we invite you to join us again next Wednesday at 2 p.m. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. And now I'd like to introduce our speaker today, Dr. Jean Storm. Dr. Storm is Medical Director at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again today.
Thanks, Kathy. And I am so happy to be here talking about one of my favorite subjects, which is patient-centered care. Another one of my favorite subjects is patient safety. But I will say, I think patient-centered care, if you follow patient-centered care, that really encompasses almost any care of a resident in a long-term care facility or any healthcare environment. I love the title of this presentation. I will say I had a little help with AI to craft the title, but I really feel if we want to pick a true north in healthcare quality, picking patient-centered care is really not going to steer anyone wrong. If we focus on the patient in front of us, the human being in front of us, and we respect that human beings' preferences, and we lead all of our actions and our words with respect, we really can't go wrong. So learning objectives through these two webinars that we're going to be doing this week and next week, we're going to talk about the core principles of patient-centered, person-centered care, and how significant that is in shaping medical decision-making, especially within long-term care facilities. I'm going to say, in my experience, I really feel like person-centered care has not been adopted universally in long-term care facilities, and we really have a long way to go in culture change. We're also going to talk about the practical implications of person-centered care on patient outcomes, treatment strategies in the context of long-term care settings. And we're also going to be talking about the impact that person-centered care can have on staff in promoting staff stability, retention, and really engaging our staff. And then we're going to talk about strategies for physician and physician extenders and anyone who is taking care of residents to integrate and promote person-centered care practices to enhance quality of medical decisions and overall care delivery in our facilities. I love this quote: "The good physician treats the disease, the great physician treats the patient who has the disease." And I don't know if everyone is really aware of how our biases affect us in how we talk to patients, in how we approach patients, and how we treat patients. And we often approach our residents thinking about their disease process. So maybe you see a resident with dementia who is having behaviors that you feel are problematic, like they're exit seeking or they become combative with care. And so you just see that disease process, you just see those behaviors instead of seeing that resident who's perhaps fearful, who is perhaps confused. We know that individuals, even who are out in society, act poorly when they're fearful, when they're confused, when they're misunderstood, when they're disrespected. So you can understand an individual who has limited cognitive capacity, how that is going to affect them when they're treated poorly. So we really have to look at the human being who's in front of us, and that is the cornerstone of person-centered care. So if you've seen any of my presentations, I bring up a lot of cases. So we're going to start with a case. An 82-year-old male is admitted to the skilled nursing facility after a hospitalization for end-stage congestive heart failure. He refused many interventions during his stay, including dialysis. So you might say, sounds like a non-compliant patient's non-compliant. I would encourage you, instead of using the term non-compliant, to adopt the term non-adherent. So, we have, as a patient, you have the right to refuse care, to choose what care you would like. So this resident is admitted to the facility as a full code. The attending physician talks to the resident and his wife the day after the resident is admitted, and they discuss advanced care planning and code status at the initial meeting. So this happens every day, right? In facilities all across the country. And maybe this form is utilized. This is from Pennsylvania. There's a similar form in West Virginia. This is the orders for life-sustaining treatment. And there is a version of this form in every single state. And this form typically guides the conversation for advanced care planning when we're trying to figure out what the residents' wishes are for end-of-life care, right? Typically, I will say, in the facilities where I have been medical director, this form is filled out for every single resident who is admitted. And if you do things differently in your facility, I would love to hear about it. You can put it in the chat. I will say, I've heard medical directors say this should only be filled out if a resident has a terminal diagnosis or is end of life. Certainly can be done. I will say this may be a starting place to guide the conversation for determining what a resident's end of life wishes are. If their heart stops beating, they stop breathing. That's usually how I start the conversation. And you can see in the first portion, there's a choices of, if the resident wants CPR, meaning if their heart stops, they stop breathing, they want a healthcare staff member to perform CPR and attempt resuscitation or not. So if you find a resident who's without a pulse, without a heartbeat, and they're not breathing, that means we do CPR or we don't. And then the second portion is medical interventions. We have comfort measures, means we typically just treat in the facility. We treat for comfort. We are not doing life prolonging measures. Then we have limited and additional interventions, which is you can do some care, as in described in the comfort measures, but we can transfer to the hospital. We may not transfer to the hospital. We are typically doing some life prolonging measures, but not all. So we're not going to put the patient on a breathing machine, on the ventilator, or a full treatment is everything, intubation, all of it. And then we have a section for antibiotics. I think this is a little bit of a gray area because, this is no antibiotics, determine maybe we do some, and then use antibiotics if life can be prolonged. Like very difficult, because I don't know if there's an in-between between use antibiotics and don't use antibiotics. And then we have artificially administered hydration and nutrition in section D, and that is involving IV hydration or a feeding tube. So these are all things to kind of guide a conversation around end of life, but it certainly should not be limited to just this form. Many other preferences that should be discussed. So person-centered care, the definition, we're treating patients as individuals, and they are equal partners in the business of healing. They are equal partners in their care. It's personalized, tailored for the patient, coordinating. It's empowering. We're empowering the resident to be involved in their care, and it recognizes the individual's potential to manage your own health. And think about in your own facility how often this is really happening. Maybe it's not happening a lot. Maybe, and think about this is fairly common. A resident comes into the facility and maybe they are admitted with an opioid pain medication like oxycodone, and they're not told about what's going to happen over time. If maybe they will develop a tolerance, they might develop withdrawal if that medication is stopped. We're not giving the patient all the information they need in order to make a good decision. So this is a very different way of doing things. The main components of patient-centered care: autonomy. This is illustrated through informed consent, like that example that I talked about, opioids. We're really telling the resident, by taking this medication, you are going to have pain relief in the acute period, but over time, you may develop tolerance. And then if you abruptly choose to stop this medication, you may go through opioid withdrawal. I'm sure this is not being done on a routine basis. We're not telling residents, we're not providing education. So then, they're given the right to refuse. And then it takes into account the individual's situation, their limitation, all their capabilities. Respect. I think a lot about respect if in our intent. So if you approach a resident under your care with the intent to respect them, that should be just a basic. That should just be common sense. But a lot of times, I don't think we're really thinking about what our intent is when we approach a resident under our care. So we want to make sure that we have a deliberate and intentional demonstration of regard for the residents' interests and well-being. And then we have empathy. We understand the other individual's feelings, the resident's feelings, and that develops the therapeutic relationship. Very important. So when we compare traditional care to person-centered care, traditional care decisions about policies, procedures are made exclusively by management. So you probably didn't realize that person-centered care is more than just one individual's, the staff member's relationship with a resident. It's an entire culture change. So in traditional care, leadership is making all the decisions. So that kind of idea, that kind of culture in the facility is going to translate to the care, right? So if leadership is making all the decisions and the leadership doesn't get much input from staff, that's going to translate into the care of the resident, right? So we don't get much input from the resident about their preferences and what kind of care that they want. In traditional care, frontline staff are not involved in decision-making process, but in patient-centered care, we're empowering staff as we're empowering residents. We're empowering everybody, giving them knowledge so they can have input into the decision-making process. And in traditional medical model, care is driven by diagnoses, care tasks, and individuals perform the tasks. And in person-centered care, we're giving resident choice and input around their care. And that's how we formulate our care plan. This case might sound crazy to you, but I would encourage you to have an open mind because this type of care can work. An 82-year-old wheelchair-bound resident sustains a femur fracture in the facility. The resident decides against hospitalization for repair of the fracture. The resident is allowed to make this choice. Maybe in your facilities, you don't give the resident the choice. If they have a fracture, they go to the hospital. The resident is allowed. This is an option. This is an option that is available. The resident's physician collaborates with an orthopedic surgeon to make a follow-up plan for imaging studies, and a pillow splint is applied. That's just a splint made of a pillow that's wrapped around the fracture using an ACE bandage to allow the resident to remain in the facility for management. The resident continues to enjoy quality of life in the facility, activities, visiting with family, and the fracture is determined to be healed after 8 weeks. This works. This can happen. So just because the orthopedic surgeon says you have to send to the hospital doesn't mean you do. So this is just an example of how customized, tailored care can work. Patient-centered care benefits to residents. They enjoy personal autonomy and the ability to direct care. They have access to choices. You tell them about their choices. You tell them about their options. And then they have an environment, they live in an environment that encourages trust and respect, and they collaborate with staff. And the staff prioritize the resident preferences and needs. And then we have improved quality of life. And that's what we want to do. We want to provide the best quality of life for the residents. And then we see staff benefits because the staff is finding meaning in this relationship that is being established. They have better partnerships with residents. They understand resident preferences. And when staff understands resident preferences, they're better equipped to anticipate resident needs, family needs, and then act accordingly to what is needed at the time. And then they feel valued because they're providing residents with what residents needs. So again, it makes sense, but it really will require a culture change in the facility. And culture transformation is a continuous process in which a nursing home transitions from being a facility, an institution that's driven by tasks and schedules, to a place where we're really honoring a resident's desires and requirements. We're creating a home where residents are respected, their choices are respected, their preferences are respected, and we're delivering care that's tailored to their needs. And I love this last bullet point: culture change reflects certain values. The values are choice, dignity, respect, self-determination, and purposeful living. I feel like those should just be on a big sign every facility door. And it's just super important. It can make a huge change. Person-centered care and person-directed care. The environment is going to reflect a home and a community environment for everyone who lives and works there. Really changes everything. And leadership is dedicated and committed to creating and cultivating an environment. Feels like a home setting. I'm sure you know nursing home administrators who are dedicated to doing this, and the change is amazing. It's like those facilities are exemplary, you know, when leadership is really dedicated to that. Direct care workers are engaged and empowered to make decisions and is supported by leadership. This is an engaged, empowered staff, and we know an engaged and empowered staff are more likely to stay in a facility to work. So you're going to retain your staff, you're going to have staffing stability. Elements of culture change: there's resident direction and care and activities, there's close relationships between residents, family members, and staff, and you really need to cultivate that. Staff empowerment, I talked about. Collaborative decision-making, we're going to be talking about in the part 2, and then the continuous quality improvement process, which we should all be doing in our facilities. Language of culture change. Think about the language we're using with the residents under our care. I just want to point out, victims of, suffering from, really important. We probably should change to living with. And then how many times have you heard in a nursing home, you need to sit down, you need to sit down? I'm sure just hundreds of times a day. Instead, we should be saying, would you like to? I would like you to. Really makes a big difference in how we're approaching our residents. So thinking about resident direction and care and activities, allowing residents to go to sleep and wake up when they choose, making a preferences list. Great to do a life story interview and document. And then ensuring that preferences are truly important and met. And there was a study that was done that I'm going to be talking about that really illustrates how residents feel that their preferences are unimportant many times and not met many times. So can you imagine living a life where you felt that the individuals caring for you felt that your preferences were unimportant? So, you know, I don't like spaghetti, but they're giving me spaghetti every night. So my preferences are unimportant to them and not met. So really important, you know, and things can be changed in simple ways. So in talking about the life story template, I'd encourage you, if you are interested in implementing the life story into any of your processes, visit this. The template is available at the Alzheimer's Association, and it includes just, you know, a background. You list where the resident was born, where they were born, when, the mother's name, the father's name, brothers, sisters. You can include pictures, you know, their early life. Really great way to make a resident feel important. I would encourage you to implement that. So Another case, a 52-year-old is admitted to the facility following a hospitalization for complications from liver cirrhosis. During the pandemic, he becomes progressively more depressed due to lack of activities such as bingo, which was his favorite activity. The director of activities resigns from the facility during the pandemic. Activities are resumed a few months later, but very disorganized due to lack of director. And a CNA suggests that the resident call the bingo game. They say, I'll help you organize the bingo. I'll get out all the supplies, but how about you call the bingo game? The resident organizes the activity, enjoys the experience, and asks to continue helping with organizing activities. So this is empowering a resident to be engaged in activities and finds joy and meaning in doing that. So super easy, right? And super impactful. So I talked a little bit about unmet and unimportant preferences. This is data that was taken from 2012 to 2017 in MDS assessments. And there were 52,000 assessments from about 26,000 residents, so a large number of residents. 3.3 to 5.1% of residents reported that at least one or more of their preferences were important but weren't met. So they're saying, I feel like the facility felt like my preferences were important, but they didn't feel like they were important enough to actually meet my preferences. And 10 to 16.6% reported that 4 or more of the 8 preferences were not even important. So it's disrespect, right? That's a feeling of disrespect. And residents who had depressive symptoms and poor physical and sensory function were more likely to report unmet preferences. And residents, this is the hardest thing for me to see, that residents with poor physical and sensory function, residents who are living in rural facilities, and facilities with fewer activity staff hours per resident were more likely to report unimportant preferences. So we have a long way to go. We have a lot of residents who are feeling like their preferences are unimportant and unmet. This was a study that was looked at 2 long-term care facilities, and they looked at the interactions between staff and families, and they compared them. So the 2 facilities were Sweet Dell and Safe Harbor. And as you can see, when describing staff-family interactions, both facilities described the interactions as difficult, problematic, and time-consuming. Yes, they can be. Having difficult, hard conversations is hard, right? It's difficult, and they're time-consuming. But as you can see the difference, Safe Harbor described the staff-family interactions also as helpful, important, and trusting. So the interactions not only were difficult, they were also helpful. So we really need to encourage staff to say, look, we're going to do hard things, but it's also going to be meaningful. We're going to have difficult conversations, but they're also going to be helpful. We're going to have problematic conversations, but they're going to be important conversations. So we really need to encourage our staff to see it as both. The important differences of the 2 facilities is that staff, as I said, at both facilities expressed frustrations, but at Safe Harbor, where we had that they also saw the interactions as helpful and important, the anger directed toward a resident family was not tolerated. They did not tolerate anger directed at any family or resident. Safe Harbor also utilized a communication system where the admissions director contacted families at 24 hours, a nurse contacted at 48 hours, and a social worker contacted at 72 hours. So tremendous amount of communication initially on admission. And then management staff also was involved in angel rounds where they would follow up with family members. So these would be director of medical records, say a social worker, and they would, have a resident, and they would see the resident, and they would write a note to a family member and say, saw that, Mr. Smith was engaging in activities today. We had a singer, just a follow-up note. So communication, super, super important. I just kind of wanted to finish up talking about some of my own personal reflections of being involved in many nursing facilities over 20 years. I've always brought my children into facility, and I feel like, I would bring my children in with when we had, when I was rounding on the weekends, say on a Saturday or a Sunday. They're very young in these pictures. They're not young anymore. They're teenagers. But and staff and family members maybe would see them walking in the halls and they would ask me and we would have a conversation. It really, for me, helped me connect to family members to say, look, this is my family. I'm, meeting with you. The resident is your family, and we can really engage as human beings. And I think that is huge part of person-centered care. And I became very involved I've become involved in many facilities that I've been medical director. This one slide, I am stirring apple butter at a resident and family fall festival at one of the facilities where I was medical director. And again, engaging with residents, engaging with family members at these events, to be a human being. And I included this picture because I thought it's something that I really remember from my time at this facility. This was during a party that a nursing home administrator had for me when I had to leave the facility. I was moving out of state, and all the staff wanted me to try biscuits and gravy in West Virginia, and I had not tried biscuits and gravy. So this is me trying biscuits and gravy. So, we have these human interactions. I think it's super important to encourage staff to do that, to enable opportunities for staff to do that. So tips: attempt to engage family members to be part of the healthcare team. I think that this is really crucial and it's really useful. And then if you have a staff member who is very good at communicating with family members, they do a great job, they don't get rattled, they don't find it difficult, maybe have that staff member write a tip sheet so that all staff members can maybe learn some crucial points, to learn. Create an atmosphere where staff can bring their own family members in. Maybe you have events on the weekends where you encourage staff to bring their family, encourage the resident families to come, and everyone is interacting as human beings. I think that's very important. And it's really important to understand that communication at the very beginning of the resident's day is so important. I don't know how many times when I've gone in as a medical director or attending physician to talk to a resident, and the family member has been there, and they're maybe the day after admission or the day of admission, and they're very afraid because they don't understand what goes on for a nursing home stay. They don't understand what's happening. No one has kind of explained things to them. So I think at that point, it's really crucial to have seamless transition and have the communication be strong right at the very beginning. So I would encourage that. And we're going to be talking about more of this and more tips next week. So here's my contact information. If you have any questions, always feel free to reach out.
All right, thank you, Jean. In a moment, we'll begin the Q&A portion of today's webinar. If you have a question or comment, please submit it using either the chat or the Q&A tool in your Zoom menu. I'd again like to invite everybody to next week's webinar, which will be part 2 of today's presentation on person-centered care's influence in long-term care facilities. That will be the same time and place next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at ccaudell@qualityinsights.org and I will get you on that list. And now I'm going to put my information in the chat along with Dr. Storm's information. And there are no questions so far. Jean, is there any closing items you'd like to say before we wrap up today?
I would just love to encourage everyone to commit to adopting person-centered care in your facilities. And we're going to be talking more about that next week.
Thank you. And it looks like there's no questions, so I think we can go ahead and wrap up for today. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. And if you have a couple minutes to fill that out, we would appreciate it. Dr. Storm, I'd like to thank you for joining us today and for this great presentation. And I'd like to thank everybody here for coming today, and we hope to see you again here soon.